Hi, my name is Natalie Benet, and this lecture covers epithelial ovarian tumors. My contact information is below should you need to provide feedback. Today I will briefly discuss the normal anatomy of the ovary, followed by most of the tumors of the ovary as designated by the WHO classification scheme, certainly the most common types. Unless otherwise noted, my source material is the 2014 WHO classification of tumors of the female reproductive organs, as noted here. To discuss anatomy, the ovary is a firm almond-shaped organ measuring about 3.5 centimeters long by 2 centimeters wide and 1 centimeter thick, attached to the back of the broad ligament by the mesoovarium, through which blood vessels pass to enter the hilum. It is attached to the pelvic wall by the suspensory ligament and the uterus by the ovarian ligament. The ovary is located behind the fallopian tube grossly. It is smooth in females who have not yet undergone puberty and becomes more cerebriform over time with ovulation. The ovary is divided into two layers, including the outer cortex, which has the ovarian follicles and stroma, and the medulla, which is more centrally located and contains loose connective tissue and blood vessels with lymphatic spaces and nerves. Where does ovarian carcinoma come from? Originally, the epithelial ovarian tumors were thought to arise from so-called surface epithelium of the ovary, which resulted from metaplastic transformation of mesothelium, but this theory has been recently challenged, especially regarding serous carcinomas, but the name still persists. The cell of origin for each different kind of ovarian carcinoma is different and depends on tumor type, which we'll review as we review different tumors. We'll start today by talking about serous tumors. However, first, a brief aside about classification schemes. Historically, almost all serous tumors involving the ovary were considered to arise from the ovary, but recent developments have led to a different understanding with this dualistic model. Two types, broadly designated into type 1 and type 2, are recognized. The prototypic type 1 tumor is low-grade serous carcinoma, as designated on the left, with high frequencies of KRAS and BRAF mutations, but no p53 mutations, while the prototypic type 2 tumor is high-grade serous carcinoma, characterized by high levels of genetic instability and p53 mutations. These two tumors developed by different pathways. The precursor lesion for low-grade serous carcinoma is borderline serous tumor, also known as atypical proliferative serous tumor. In recent years, an alternative origin from the surface epithelium metaplastic theory of tubal origin of high-grade serous carcinomas has arisen. The non-invasive intraepithelial lesions in the fallopian tube have been designated as serous tubal intraepithelial carcinomas, or STICs, as designated on the upper right-hand corner. They have cytologic features identical to high-grade serous carcinomas, and this theory is further supported by finding STIC lesions in up to 60% of women with high-grade serous cancer. This model has limitations, as some tumors appear to defy classification, or very rarely you can have type 1 tumors that transition into type 2 tumors. Of course, there's always exceptions to every classification scheme, but it's helpful to at least think about this in terms of molecular characteristics of lower grade versus higher grade tumors. And after all, what would pathology be without classification schemes? So back to serous tumors, we'll start by talking about serous cystadenomas. Like all serous tumors, they are characterized by epithelial cells which resemble those in the fallopian tube, including cilia. The epithelial component may be associated with a rather thin cyst wall designated as a cystadenoma, or with a fibrous wall designated as a cystadenofibroma. These tumors or lesions arise in patients ranging from 40 to 60 years old. Grossly, this cystic tumors can range from 1 to greater than 30 centimeters in greatest dimension and have a smooth outer surface. You can see here a smooth lesion with that band arising on the outer portion is the fallopian tube, with the fimbria sort of on the right edge of the ovary there, or the ovarian lesion. When deflated, these lesions show smooth lining within the cyst wall, no solid areas. That's important. However, some cystadenomas are multiloculated, but still the inner lining of all the cyst walls are smooth. On histology, they are composed of cysts lined by non-stratified or stratified to cuboidal to columnar cells resembling fallopian tube epithelium, and you can see those cilia. They look like hair sticking off the upper portion of those cells. Whereas an adenofibroma shows that same ciliated cyst lining with a fibrous stroma component. So the next tumor is serous borderline tumor, also known as atypical proliferative serous tumor. These are synonymous terminologies. These are non-invasive tumors that display greater epithelial proliferation and cytologic atypia than benign serous tumors, but less than low-grade serous carcinoma. The mean age of these patients is 42 years old, and these tumors are less common than high-grade serous carcinoma, and they typically occur at a younger age. Clinically, these masses are confined to the ovary in a majority of cases, and they are generally greater than 5 centimeters. This is a cut view of a serous borderline tumor / atypical proliferative serous tumor, which shows the typical finding of excrescences, typically seen within the inner portion of the cyst. Histologically, these tumors are characterized by hierarchical branching patterns, showing branching from large to progressively smaller papillae. Anecdotally, I think these resemble fingers coming off of a hand, which will make more sense when I talk about the other version of this tumor, which does not show hierarchical branching. These papillae are lined by non-stratified or stratified cuboidal to columnar cells, typically ciliated. Marked atypia and mitotic activity are not present. Some cases of serous borderline tumor / atypical proliferative serous tumor show eosinophilic cells detached and sometimes floating into the glandular lumen, but also involving stroma. You can see at the blue arrow. And in the cells involving the stroma, this is known as microinvasion. And these foci have to measure less than 5 millimeters, and they have no adverse effect on survival. Whereas microinvasive carcinoma, which can also arise in this setting, is a different entity. These are foci of invasion which resemble low-grade serous carcinoma, which we will cover in just one moment. This is an example from a published paper as cited above, showing relatively uniform cells with rounded nuclei with small punctate nucleoli and higher nuclear to cytoplasmic ratios as compared to the focus of microinvasion with those plump eosinophilic cells that we talked about in the prior slide. Implants are another feature associated with serous borderline tumors, aka atypical proliferative serous tumors. Originally, these were designated into non-invasive and invasive subtypes, terminology which is still used in many settings today. These are examples of non-invasive implants. In Figure A, this is an epithelial type implant showing hierarchical branching papillae with detached clusters of cells associated with non-fibrous stroma and no invasion, whereas in parts B and C, these are what's known as non-invasive desmoplastic type implants, which are associated with reactive or dense fibrous tissue, compared to examples of invasive implants, which for all intents and purposes resemble low-grade serous carcinoma and should be designated as such. Prognosis for patients with these implants is that, prognosis for, in general, for patients with serous borderline tumors / atypical proliferative serous tumors, if it's confined to the ovary, are excellent and no different than the general population. However, patients who have these invasive implants do have more complications, including local recurrence and adhesions. Patients may recur as low-grade serous carcinoma with these tumors overall, which happens in about 5% of cases. Now we'll move on to serous borderline tumor micropapillary variant / non-invasive low-grade serous carcinoma. And I'm spending extra time on these because I know when I was first learning about serous tumors, the terminology can become confusing. But I think if you approach it in a stepwise fashion, it's a little bit better. So now we've made it to the serous borderline tumor micropapillary variant. These are non-invasive tumors displaying non-hierarchical branching. So we talked earlier about the fingers coming off the hand. Branching architecture feature micropapillary or cribiform patterns, and they're composed of rounded cells with scant cytoplasm and moderate nuclear atypia. Grossly, these tumors share features with serous borderline tumor / atypical proliferative serous tumor. Histologically, they are characterized by non-hierarchical branching, which means there is no intermediate branch, i.e. it doesn't appear as though the thin, delicate papillae come off something like the palm of your hand. It's almost like your fingers are just coming off of your wrist. The micropapillae have scant or no stromal cores, in contrast to the serous borderline tumor / APST, which we talked about in the former slides. These lesions are also known as medusa heads, which you can see here. Small nuclei are sometimes present, and mitotic activity is typically low. The nuclear to cytoplasmic ratios are higher than that noted in serous borderline tumors / APST, and cilia are not sometimes visible, or typically visible, really. A distinctive variant of this tumor shows fusion of the papillae to form cribiform architecture, as noted here. Just keep in mind that not all micropapillary variant has micropapillae per se. Regarding prognosis in these patients, tumors that are confined to the ovary do not differ from the general population in terms of prognosis. However, compared to the serous borderline tumor / APST patients with this tumor present more frequently at an advanced stage, which does affect prognosis. And additionally, these patients show a higher propensity towards having those invasive implants that we talked about earlier. Moving on now to low-grade serous carcinoma. It's an invasive carcinoma with distinct patterns showing low-grade malignant cytologic atypia. Histologically, these tumors are characterized by many patterns, including single cells in an irregularly shaped small nests, which haphazardly infiltrate the stroma, as noted here. The cells themselves show mild to moderate nuclear atypia and may contain single prominent nucleoli. Necrosis is very rare and pneumoma bodies are frequent. You can see the calcifications here. Regarding prognosis for these patients, it's much better than high-grade serous carcinoma. However, these tumors do not respond well to chemotherapy and are prone to recurrences. The next tumor we'll talk about is high-grade serous carcinoma. It's a carcinoma with papillary / glandular architecture or solid patterns with high-grade nuclear atypia. The majority of deaths attributed to ovarian cancer are caused by high-grade serous carcinoma, which disproportionately affects women in Western nations. Grossly, these tumors are often large with necrosis and large solid areas. Normally, the tumors are large, but tumors less than 1 centimeter are present in 1/3 of patients. They're often bilateral and exophytic, as in this case, which demonstrates solid and papillary growth with fluid-filled cysts and necrosis and hemorrhage. Histologically, high-grade serous carcinoma is composed of solid masses of cells with slit-like spaces. Necrosis is frequent. Nucleoli are large, and there's often hyperchromasia and pleomorphism with bizarre shapes and some multinucleated forms. Immunohistochemically, these tumors are positive for WT1 and show mutational pattern for p53, which is defined as either diffuse staining greater than 60% of the cells or absence of staining. This is a cytologic touch preparation of high-grade serous carcinoma, which shows marked variation in cell size with background necrosis. This is a separate cytologic preparation stained with Diff-Quick, showing bizarre shaped nuclei. nucleoli, and apoptosis with background necrosis. Regarding prognosis, approximately 75 to 80% of patients have advanced stage disease at the time of presentation, and almost all patients with high-grade serous carcinoma are treated with cytotoxic chemotherapy. Genetic susceptibility for high-grade serous carcinoma, hereditary predisposition can explain 15 to 20% of newly diagnosed high-grade serous carcinomas. The most frequent mutations are associated with BRCA1 and BRCA2 genes. Virtually all BRCA-associated ovarian cancers exhibit high-grade serous morphology. The risk for ovarian cancer also occurs with mutations in other DNA repair genes, accounting for up to 6% of additional germline mutations in ovarian cancer. Now we will move on to mucinous tumors. We'll start with mucinous cystadenoma/adenofibroma, which accounts for 80% of all primary ovarian mucinous tumors. They're seen in a wide age range and are typically unilateral with smooth surfaces, but can be multilocular or can present with a unilocular cyst. Histologically, the tumors are composed of multiple cysts and glands lined by simple, non-stratified mucinous epithelium. Approximately 10% of cases are associated with a dermoid cyst or a Brenner tumor, possibly pointing to a cell of origin. Mucinous borderline tumors / atypical proliferative mucinous tumors are composed of mild to moderately atypical gastrointestinal type mucin-containing epithelium with proliferative areas greater than that noted in mucinous cystadenomas. They occur across a wide age range and commonly present with a unilateral mass confined to the ovary. Grossly, these tumors range from several centimeters up to 50 centimeters, and they usually have smooth external surfaces and are composed upon sectioning of small to large cysts containing mucinous material. However, solid areas can be seen. On histology, the cysts are lined by gastrointestinal type epithelium in the form of gastric pyloric epithelium or goblet cells, or neuroendocrine cells and occasionally Paneth cells. The epithelium shows tufting as noted here and sometimes pseudostratification. When present as a component of or arising in the background of a mucinous cystadenoma, the areas of proliferation must comprise greater than 10% of the epithelial volume for the tumor to be classified as an APMT or borderline mucinous tumor. Mitotic activity can be brisk. Regarding intraepithelial carcinoma, within tumors with backgrounds of APMT or borderline mucinous tumor, there can be areas with focal marked nuclear atypia confined to the epithelium, and these are designated as intraepithelial carcinoma. This is an additional focus of intraepithelial carcinoma with marked nuclear atypia and some mitotic activity. Similar to serous tumors of the ovary, microinvasion can be present in these borderline / atypical proliferative mucinous tumors, but should be less than 5 millimeters in greatest dimension. Prognosis for borderline and APMT tumors is excellent, even in those with intraepithelial carcinoma, provided the majority are confined to the ovary at presentation. Mucinous carcinomas are malignant epithelial tumors composed of gastrointestinal type cells containing intracytoplasmic mucin. Grossly, these tumors are large and unilateral with cut surfaces showing complex solid and cystic masses. Surface involvement is absent in most cases. Histopathologically, there is often a continuum of features ranging from benign to borderline to carcinoma. The invasive pattern of mucinous carcinoma may either show this confluent glandular pattern noted here, or can be characterized by an invasive pattern noted here with destructive stromal invasion, which is less common. Now we will move on to endometrioid tumors of the ovary. The first being endometrioid cysts. Cystic forms of endometriosis may or may not be associated with endometriosis elsewhere in the pelvis, and they are the more common causes of ovarian enlargement, or among the more common causes. Grossly, the cyst can range up to 15 centimeters. Cyst contents are typically dark brown due to old hemorrhage and are colloquially known as chocolate cysts. The classic cyst is lined by endometrial epithelium overlying endometrial stroma and is associated with hemorrhage and hemocydin-laden macrophages, which you can see those brown cells right underneath the epithelial cells towards the top of the photo. Endometrioid adenofibroma is a cystic lesion lined by benign endometrial epithelium, characterized by a predominance of fibrous stroma. Endometrioid borderline/atypical proliferative endometrioid tumors show crowded glands lined by atypical endometrioid type cells lacking destructive stromal invasion or confluent glandular growth. They can either show adenofibromatoid growth patterns as noted in these photos or intracystic growth patterns. Endometrioid carcinomas are malignant epithelial tumors resembling endometrioid carcinoma of the uterine corpus. They show back-to-back arrangement of glands with confluent and cribiform patterns. Destructive stromal invasion is sometimes noted. And squamous metaplasia can be present, just like in the uterine corpus. Moving on to clear cell tumors, the classification scheme is similar to that of the other epithelial ovarian neoplasms we have already discussed. However, the first two types in this category are exceedingly rare, so I will focus on clear cell carcinoma. It's a malignant tumor composed of clear eosinophilic and hobnailed cells, displaying a combination of patterns. It is the ovarian tumor most frequently associated with ovarian or pelvic endometriosis, and also the most common epithelial carcinoma associated with paraneoplastic hypercalcemia and venous thromboembolism. The tumors are usually unilateral. They show different patterns, including tubulocystic, papillary, and solid. The tumor pictured here shows a papillary pattern with clearing of the cytoplasm, and mitotic figures are relatively uncommon. Regarding genetic susceptibility, with Lynch syndrome, I just wanted to mention this after covering endometrioid and clear cell carcinomas, because ovarian cancers associated with Lynch syndrome are predominantly clear cell or endometrioid in histology, and Lynch syndrome is characterized by germline mutations in mismatch repair genes. The next section we will focus on Brenner tumors and borderline or atypical proliferative Brenner tumors. We'll focus on those predominantly because malignant Brenner tumors are exceedingly rare. Brenner tumors are defined as tumors composed of nests and islands of transitional type cells resembling urothelial cells embedded within fibrous stroma. Here you can see oval to irregular nests of transitional type cells embedded in a fibrous stroma. The nests can be solid or exhibit central cavities which can contain mucinous material or, as in this case, eosinophilic material. Borderline Brenner tumors or atypical proliferative Brenner tumors are neoplasms of transitional cell type resembling low-grade, non-invasive urothelial neoplasms with an epithelial proliferation beyond that noted in typical Brenner tumors. It resembles low-grade, non-invasive papillary transitional or urothelial tumors. Mucinous metaplasia is often present, as are areas of more typical appearing Brenner tumor as noted in the previous slides. And regarding the cell of origin of Brenner tumors, some think it's Walther rests, but perhaps not all Brenner tumors come from those rests. Now we'll move on to seromucinous tumors. Lesions in this category are characterized by epithelial lining with two or more cell types, as indicated by the name. Serous and mucinous are the most common. Today we will focus on seromucinous borderline tumor / atypical proliferative seromucinous tumor. which is defined as non-invasive proliferation of an epithelial tumor composed of more than one epithelial cell type, most often being serous and endocervical type mucinous. Architectural features similar to that of serous borderline / atypical proliferative serous tumors are noted. The epithelial lining of the papillae is typically stratified and composed mostly of endocervical type mucinous or serous epithelium. Cytoplasmic eosinophilia is often prominent, and edema of the stroma of the papillae is common. Like other borderline tumors, microinvasion, intraepithelial carcinoma, and micropapillary features can occur. So now I've covered the serous, or the normal anatomy of the ovary, and then the different classifications, including serous tumors, mucinous tumors, endometrioid, clear cell, Brenner, and seromucinous tumors. That brings us to the end of our talk. This is a general overview of epithelial ovarian tumors. In the future, I hope to make more specific videos, especially for those farther in training. However, in the meantime, please send feedback to the above methods of communication. And if you're watching this on YouTube, I would appreciate it if you fill out the evaluation below to let me know how I can improve. Thank you so much.